At the end of those 3 sessions, I asked Doctors Haake, Zivadinov, and Beggs to come to the podium and answer questions for the audience. Mark, I have a question. That's a very interesting remarks about the cautionary notes regarding people with normal flow. And I was wondering, what percentage of the patients that you study with MS have normal jugular flow? And have they had correlation, or is there any correlation with CCSVI diagnosis by ultrasound? So, do you have that information?
I don't have the correlations done yet. We are certainly working on it. Don Ponick showed that his ratio of people who, tended to recover. I don't think they found any, if I quote David Hubbard correctly, that they found any correlation yet with flow. I think one of the interesting questions would be to see if those people who did not benefit had, in fact, many of them had normal flow. We haven't done that analysis yet, but that's a very important point. And then comparing to ultrasound, I think, is also a very important thing, given that many sites are focusing on ultrasound. It would be very good to compare the MR to the ultrasound data.
Well, we have to explain why a significant percentage of patients have no clinical improvement after treatment of stenoses. And perhaps, that is the correlation we need to do for predictability.
So in the last phase of our study, the CTVD study that including 1,000 subjects between patients, controls, and patients with other neurologic diseases, in last 150 we implemented the phase contrast velocity flow studies, MRV, with your program, and we are doing concomitantly velocity studies in ultrasound. So it's extremely interesting database, because we will be able to have a data between MS patients, healthy controls, and other neurologic diseases in about 150 individuals that will have velocities and flow both in MRV and in Doppler. And in that sense, it will be extremely interesting to look the correlation between, kind of CCSVI protocol parameters versus flow velocity studies. I think that the only paper, as you know, until now is the depth study that looked at that, and I don't think he appropriately assessed the CCSVI parameters, but probably he did very good flow and velocity studies. So that's another, I think, a very important thing. I wanted to say that we looked relationship between the amount of severity parameters of CCSVI determined by the venous insufficiency severity score that was created by Professor Zamboni in respect to lesion volume. No relationship was found. We tried to diversify the damage in the left hemisphere, right hemisphere, and correlated with the left and right jugular vein. No correlation was found. We tried to do infratentorial, supratentorial, periventricular. No relationship was found. So I think that, and the question is also at which stage you are doing that, because maybe if we would have enough early patients until the damage, the white matter damage is not widespread, maybe you would be able to find some correlation respect to the amount of stenosis. But clearly, once the disease is there, the lesions are shooting everywhere, and so this was kind of a little bit disappointing, because this kind of hemispheric laterality data studies did not show any correlation.
So let me just make one comment on that. I think that that adds one more variable. Right now we haven't pulled age out of this or length of duration of MS, and I think that's extremely important. but it also indicates why, with all these variables that we're talking about here, that can be classified as CCSVI, and there are dozens and dozens of variables like this. The only way to really address these questions is to be doing thousands of cases. You won't be able to address the age issue unless you have at least 20 per bin per age, and unless you can break those up into the different types of parameters, which is left and right jugular problems or vertebral problems. So we need really to be working together with a lot of groups here to create this database that lets us assess those questions. We don't want to wait 20 years to do that. And I think that the group of people that's here has already demonstrated very strong collaborations. I think it's critical that we get such a working group together so that data, at least some type of data, normalized data, or some forms of both angioimaging, ultrasound, and MR can all be shared across a database. Then we can answer these questions in 2 or 3 years perhaps instead of 20 years.
Can I shed a
Clive,
bit of
yeah.
light on this, your original question as to why some patients may improve and others don't improve? And I'm coming back to this is a purely theoretical answer, but it may shed some light on this. Come back to the simple thing that fluids are dumb. They flow where resistance isn't, where the least source of resistance. So if we come down to, if there's evidence that the sum of the resistance in the whole circuit is the resistance of the extracranial pathways, but there may also be increased resistance in the vascular bed for some reason, for some morphological changes, then you can do something about this with your intervention, but you're not doing anything about any increased resistance there. So it would suggest to me that a good place to look would be that in patients who do not improve, I would suggest that they have an increased resistance somewhere in the main kind of vessels, and therefore that would explain why you may not get the increased flows that occur. But again, that's pure hypothesis.
Perhaps you are right, because many of those patients who do not improve, when you perform Doppler sonography after the procedure, they still present with a very slow flow in internal jugular veins, but we cannot find a stenosis. There is stenosis. Even we from data venography, control venography, the jugulars are clear, but the flow is still very low. It's a low inflow.
Yeah.
So perhaps there are some problems inside the brain. Maybe there are just stenosis,
Yeah.
intracranial, or other reasons.
I won't comment on the clinical side of things, but I will just make one comment here. If you've got a system, you've got to realize that you've got to look at the whole circuit. When you're dealing with flow, if it's a sealed circuit, it can have lots of branches, but essentially what goes in comes out. Well, what comes out must be what goes in. So if you occlude that in any place, that will affect the flow in the whole system. So, we've observed one thing because we could easily tell about stenotic behavior out here. We're not too sure what's going on here, and I suspect my gut reaction would explain some of the things why some of the veins may be disappearing as well, is that actually what we've got are blockages occurring in specific locations, and blood is being channeled away from certain areas into different areas, and so you're getting like a plasticity. But at the end of the day, if that increases the resistance, that will reduce the flow. Simple as that.
Yes.
Understand better what's the role of reflux? Can reflux be a primary problem in CCSVI, or is it always combined with retrograde flow secondary to a stenosis? In other words, can a valve abnormality be involved here?
Oh, of course. The valve is, I think we have to differentiate two types of reflux. One is reflux above an obstruction and reflux without an obstruction. If the valve is incompetent, there can be reflux, but I believe without an obstruction, that's relatively simply dissipated. But if there's an obstruction, the refluxes are going to can extend into the deep veins. Any other comments?
Yeah, I would like to make a general comment. I think that, clearly we are learning a lot through all these studies in the last 2 years. about this problem. And I think what Mark said, it's completely true. I did the Doppler on myself, and I have an abnormal valve. Okay, so I think that that's why it's so important that we do really so many healthy people and understand what problems they have. We did, for example, we measured the collateral veins in 2 studies now, using really huge number of patients and healthy controls, over 300. And there is really 95% of healthy people have a big collateral vein in their neck. So to have a collateral vein in the neck, it's something really physiological. Now, what Mark said, it's extremely important. If you have a reflux, and you may have a reflux, the question is how important that reflux is. And is that a reason to go and be treated, or it's really something that all of us have, and how that really relate? And I think that flow velocity studies, whether are done, through MRI, whether they are done through ultrasound, pre-treatment, are going to play a huge role in if they are reliable and reproducible in determining who to treat, what to treat, and if it's necessary to treat. Because really it might happen, as Mark said, that you reopen something and you are creating actually worse situation than what was really physiological for somebody who had a dominant collateral anterior or exterior jugular vein that was draining that brain properly, and so that's something, we need to learn really a lot in respect to flow dynamics of the brain and of the extracranial system.
I think it's important to distinguish between reflux that lasts for longer than the cardiac cycle and reflux that lasts periodically as part of the cardiac cycle. You can explain the two very simply. If it lasts longer than the cardiac cycle, then it's not directly related to the pulsatile nature of the hydrodynamic system in the brain. What it is actually some extracranial effect that's causing the circulation of the blood that's flowing by another route, and it's drawing fluid back, so you're kind of getting this circulatory effect, and that can extend. That's affected by the respiration, but also can go past the length of the cardiac cycle. If it's in the cardiac cycle, as Mark showed there, and I really, that was great data. I'm going to show you some more stuff after the break, which kind of fits in with this. I think the role of the cerebrospinal fluid is absolutely crucial in this, because the way you've got to look at this is almost like a harmonic circuit, where you've actually got like almost like a weight, or like I was going to say a pendulum. The cerebrospinal column is actually, it's got inertia. So, the thing that tells me that if you've got something going up and down and it starts to pull a bit more, then that starts to suck. That's actually where you're going to start to see that reflux occurring. That says look at the whole hydrodynamic regulatory system and the timing of that, and I'm going to be talking about that after the break. So I won't say any more, but that's an extremely complex area, and the thing is, I would say I'm spending a lot of time looking at that, but I'm not looking at it in the context of MS patients. I'm looking at the context of just normal physiology, because the normal physiology is not understood, period. There's a lot of wrong ideas out there, and I think we've got to understand that first of all before we can then apply it to pathologies.
One last question here.
Yeah, Dr. Haake, when you mentioned that patients on your MRIs, I assume they're done supine, have normal flow, but they have they may have some intravenous abnormality. I'd be curious if they have normal flow when they sit up.
Unfortunately, we didn't do the ultrasound component of this, but one of the critical issues here, of course, is that for these patients, if they have jugular problems and the jugular veins are really supposed to take over when they're supine, that, at least for our work, we consider that the most important part of this. But to address one of Zamboni's questions, you would have to do the sitting up as well, because it may be that their jugular flow doesn't change very much, which means they're not responding properly. And that was the whole argument with the Dup paper and Zamboni's response to it, that those changes were actually in Dup's paper as well. So the MS patients have some faulty relationship that doesn't let the vertebrals take over when they sit up. I understand, just as a parenthetical comment, that I know SAODA in Italy is actually looking at building an MR system that will rotate from being vertical to horizontal. That would be certainly very interesting if they come out with a system like that.
Okay, thanks. I think break time.